Welcome to the New Books Network.
Welcome to the New Books Network. I'm Stephen Pimper, host of the Public Policy Channel, and I am very pleased today to welcome Colleen Grogan, who's the author of Grow and Hide, The History of America's Healthcare State, from Oxford University Press. Hi, Colleen. Welcome to the podcast. Lovely to have you here.
Thank you. Thank you, Stephen. It's great to be here.
So before we home in specifically on the book itself, I wonder if I might ask you to introduce yourselves a little bit to our listeners and tell them how it is that you came to this particular project.
Absolutely. I'd be happy to. So I am a professor of health policy and politics in the Crown Family School of Social Work, Policy, and Practice at the University of Chicago. And so what brought me to this book? Throughout my career, I have had two main foci in my work. One is just straight up health policy. And those questions are trying to understand the impact of health policy. And for me, that's mainly been focused on Medicaid policies with an aim to improve policies and create more health equity. And the second area of my research has been focused on health politics, which are motivated, quite frankly, by frustration. So questions like, why the hell does our healthcare system look like this? Why did we design the Medicaid program in this way? And it's this latter question that brought me to Grow and Hide. So I had a grant from the Robert Wood Johnson Foundation to research the political evolution of the Medicaid program. And at that time, because this was a while ago, no one had really delved into the antecedents to Medicaid. That is what led to the creation of Medicaid in 1965. So when I started to do research on that question, I found the bones of Grow and Hide. As someone who was trained in public health and political science, I was taught that we have a predominantly private healthcare system. And it wasn't until 1965, with the passage of Medicare and Medicaid, that the government really got involved in financing the US healthcare system. But when I started to look at historical documents, I saw much more government financing than the official or academic discourse suggested. So when I saw statements from public health leaders in the 1930s and 40s talking about our national health program and the government's role in financing that, I thought, wow, what's going on here? So what brought me to this book was actually research. And so it was sort of a series of stumbles when you're collecting data in an archive, trying to do something else. But this other thing keeps growing. I didn't set out to write this book. As I said, I thought I was going to write a book on Medicaid, but after a while, I couldn't sort of not write this book about Grow and Hide.
Perfect. So the book makes what, as you hinted at, right, to many people is going to be a surprising or counterintuitive argument, right? That we've got much more public health spending in the U.S. than we've been taught to think. And you at one point suggested it may be as much as 60% of all the money in health. So I'm gonna quote you for a second, and we'll go from there. So you write, to debunk the American myth, we must not only critique what the state does, but also deconstruct how policy actors describe the state. We must shift the historical question dramatically from why no government action to why has the American government significantly expanded healthcare spending and public provision in every historical period over the last century? And how has the state successfully hidden this public spending from view? So in the book, as you well know, you've broken this history into three periods prior to 1930, 1965, and 65 to 2020. If you're up for it, why don't we just sort of take each of those in turn? Start off by talking to us a little bit about maybe say a little bit more about what you mean by Grow and Hide by talking about that prior to 1930 period, and then we will move forward in time.
Sure. I'd be happy to. So the simple way to think about Grow and Hide is kind of as I think the quote sort of illustrated, but it's essentially substantially publicly financed system while framing it the opposite, right? And it kind of, grow and hide happens because we have this American myth that you, again, you kind of alluded to, and I talk about in the kind of introductory chapter. Um, and um, what I think is really important is that what I try to really document in the book is that it's very intentional. So I think, but as what happens with myths, I think there are political actors who know exactly what they're doing, and it's very intentional to hide the role of public financing. On the other hand, I think the myth has taken on such a large, it's doing the role that myths do, that many people that are actually quite knowledgeable, such as I said, I got a doctorate in health policy and in focusing on health politics, and kind of came away from that doctoral program holding on to this myth of a private American healthcare state. So it took a long time for me to kind of figure out how could this myth persist for so long. So as you said, if we start, why? So the first question is kind of like, why did it grow, right? And in some ways, that's the easiest question to answer, because every country has a healthcare system, right? Like we have death and disease, and at its very, very basic level, that's when the populace will say, oh, we need collective action to try to deal with death and disease, right? So like that's, if you think of like with the basic kind of what's a public good, public health, I think in every country, I mean, it started in the antiquities, right? That like we need clean water, we need clean air, we need, and the only way we can get that is through public collective action, right? And the US is no exception to that. Even though we pretend that we can have many of our public goods through private provision, that only happens through actually a pretty active state. We just kind of hide what we do. So that started to happen in a really significant way with the cholera epidemics in the 19th century. And I'm really drawing on many other medical historians in that first chapter to just sort of document this really important history around the cholera epidemics and the important rise of, germ theory and what became the kind of scientific imperative, right? And it became the scientific evidence of what local municipalities and local governments needed to do to create a sewage system, to create clean streets, to create basic sanitation, became kind of irrefutable. And so in chapter one, I just sort of document how even under, patronage politics in New York City, in the 1860s, nonetheless, the government had to really support a kind of scientific approach to sanitation, right? So even though it was for a long time funding, city inspectors who were very much part of the machine politics, it had to eventually kind of shift to really giving significant authority to sanitation leaders. And so I think that that's kind of a really important basic foundation that explains why we shifted, why public health, kind of the public health state came about. But I do think I lay out in chapter one and chapter two the importance of patronage politics in shaping the healthcare state, because public health leaders were so disgusted by local politics. And to be honest, rightly so, right? Because there were important things that needed to be done that were not being done under patronage. That they, from the very beginning, had a very anti-government discourse, right? And so sort of said, we need a non-political scientific state. The way that we do that is through scientific agencies, which they attempted to create, but also from the very beginning talked about this voluntary sector. And of course, many people, historians have written about the rise of the voluntary sector. I mean, starting with Tocqueville, right? But many others are talking about how the voluntary sector worked alongside the development of the American welfare state and how important that voluntary sector was, and actually kind of minimizing the role of government. Ironically, right? And that worked in the public healthcare state as well, so that we started to contract out. We didn't call it that then, but there was such a close collaboration with the voluntary sector that it allowed public health leaders at the time to talk about private provision, because they wanted to really signal so strongly that it was not patronage politics that was going to be involved in this.
There's a history of that rhetorical device in the sort of the welfare state literature more broadly, right? As people will say, there's a whole line of literature predominantly from the right saying, no, we had this exclusively voluntary sector in the 19th century. Government didn't need to get involved, and everything has gone to hell in a handbasket since they did. But if we look at that, we see, in fact, that lots of private provision, right, local charitable organizations, but overwhelmingly funded by the public sector. And you're seeing a very similar kind of dynamic play out here, correct?
Yeah, absolutely. Absolutely. The part that I tried to bring into this story that I think other people have also been documenting is that we, because of the way public health and medicine, the healthcare system developed in the US as very separate systems, um, we tend to think that they were always separate, right? And that public health really dealt with sanitation and population health questions. And then the healthcare system grew up separate from public health. And so that is very much a big part of part one of the book of Grow and Hide, is to show how no, actually, our healthcare system grew out of the public healthcare state. And the reason why that's important, of course, is because it shows that it was the government that created the healthcare infrastructure, and it wasn't just sort of. Again, kind of, we know that voluntary hospitals, or what we call nonprofit hospitals today, were largely kind of religious-based voluntary hospitals, came out of various religious denominations and religious orders. But we have in our heads that somehow that all came from voluntary contributions, but very little of it actually was financed through voluntary contributions.
And I
It was
think,
financed by the state.
one of the things that I think is particularly useful in that section in particular is that you've talked about sort of all of the municipal level reform, and again, this pops up in the urban studies literature and in other places, but it's not just at the local level, it's a state level and even at the federal level at this point, right? You've got boards and agencies using this sort of trying to use this scientific framework to separate it from government, but very much rooting these institutions in government itself. Yes.
Yes, absolutely, absolutely, absolutely. And I mean, the thing that's also really pretty interesting is, alongside this effort to use the voluntary sector and to call it private provision and to kind of hide the role of public financing, there was also this very direct government investment that initially didn't really have to be hidden, because there was actually a lot of support for growing the public healthcare state from the business sector, from both, across party lines, because again, the evidence for the public good that the public healthcare state was creating, again, as you point out, state boards of health, municipal health departments were able to show, $1 investment in the public health department created, this percent decrease in mortality, right? So they had, even at this very early period, sort of these cost effectiveness studies that were actually quite persuasive in allowing expansions in health agencies. This weird, anyway, maybe I should Should I stop
Well,
there?
just so one other thing there, because it's the agencies, but it's also sort of massive investments in community health centers and in hospitals, right? If I'm remembering this number right, 7,000 hospitals, right, in existence in the United States by 1928,
Yeah.
right? Largely as a consequence of government investment. However, that winds up not being apparent necessarily as activity of government.
Right, absolutely, absolutely. So, investments in hospitals well before Hill-Burton. So, the Hill-Burton Act, for those who know health policy, the history of health policy, that's typically pointed to as sort of the major federal act that was passed in the post-war period in 1946 that really developed the hospital infrastructure across the U.S. And it was hugely important, and I talk about that in part 2 of the book. But well before, as you say, by 1928, we already have the bones of the hospital system in the U.S. And it's really providing curative medicine at that time, right? That's why it continues to grow, because it's able to kind of shift from being seen, rightfully so, as a place to die to a place where curative care can actually happen. But as you also say, in addition, which I think is really important, is that community health centers, there were huge investments in clinics. And, what today we refer to as community health centers, back then we did too, or neighborhood health centers, neighborhood health districts. They came under many different names. They were all financed by local health departments, local governments. The history that's been written about community health centers is that it took off in the early 20s or kind of 1910s. It expanded a little bit in the 1920s, and then it completely died. And again, I think what we've fallen prey to a little bit in our historical understanding of this infrastructure is how it was described by actors at the time, right? So they sort of said, "Oh, don't worry, there's no more public funding for community health
Yeah,
centers."
nothing to see here. It's all fine, really.
It's exactly. But if you actually look under the hood, which is what
Yeah.
I was trying to do, it still persisted. We just called it something different and pretended that government was no longer continuing to fund these clinics, but it continued to fund through the 20s and well into the 30s and 40s.
Great. So let's use that as a segue. Let's jump to the second period, 1930 to 1965. What do you think might be what is either most important or you think might be most surprising to people about what's going on in that period?
Yeah. So one thing that I think is most surprising is that we have said for so many years now that the New Deal did nothing with regard to healthcare reform, and that's just been a longstanding, a very well established. I shouldn't say well established, but a longstanding understanding of the New Deal. And in the book, I really try to debunk that view because we didn't do national health insurance in the New Deal or anything in terms of financing health insurance. But we did, we passed public health acts in the New Deal. And those acts were crucially important in terms of financing healthcare. So, what I try to lay out in chapter 4 and then develop a bit more in 5 and 6, but really in chapter 4 is to show how public health leaders weren't really all that interested in health insurance because they saw they were already doing this direct investment in healthcare infrastructure. And if you think about it, that's similar to the National Health Service in Britain, right? The National Health Service is not health insurance. It's, we invest in healthcare infrastructure, and as a public investment, people have access to it.
Sort of like the VA system.
Like the VA, exactly. And so most public health leaders at the time saw that creating that publicly financed system as a much more rational way to provide access to healthcare for the American people than health insurance. And that argument has kind of been lost in our understanding. We've been so focused on why don't we have national health insurance that we've missed the alternative that was very much in the currency at that time. That's what public health leaders were really fighting for. Although again, depending on their audience, they would kind of hide that they were fighting for that, right? But in the New Deal period, they didn't hide it all that much because there was a lot of support for public health funding. And so at various times, they would try to then also reveal that, oh, people think socialism is a big, as Edwin Whitty, who was has been called the father of Social Security. As he said in a talk in 1938, he said, people think socialism is the big bugaboo, but let's look at how much we finance healthcare in the US. And he kind of laid it all out in this talk, which I have in chapter 4. And he says, we're already doing this. We're already doing what people are so afraid of. Why don't we just continue doing it? And then he says, even if you think we're not going to do it, even if we don't pass the Wagner bill, which was this national health program, he says, we're still going to do it. We will do it whether we pass it or not. And that's what I tried to show in chapter 4, that he's exactly right. We essentially put in place the bones of this national health program, which is investment in all the components of. There was a 5-part program. We invest in all 4 components except for the insurance side. Now I don't want to diminish the importance of insurance for making sure that there's more health equity. It's hugely important. And the consequences of Grow and Hide I talk about in the 3rd part of the book. But it's not that we didn't invest in healthcare. We did in a really substantial way.
And we've been so focused on that insurance question, right? As you made reference to, sort of the undergraduate level version of that history is, well, the Committee on Economic Security was contemplating including healthcare in the Social Security Act, but it was too complicated, too much else going on, pushback from too many quarters. So that was the first sort of abandoned effort at healthcare. But in the Social Security Act itself, there are large-scale grants in aid to states and localities, right? So as you say, we're doing it, but because our frame has somehow been so narrowly focused on this insurance question, we've missed all the other stuff that's been going on.
Yeah. Exactly.
So obviously we're compressing massive amounts of time. So folks need to go out and read the book, don't they? But let's move forward to that 3rd period, 1965 up through the present. Again, sort of where do you think the things are that are either most important or most surprising or interesting for folks?
Yeah. If I can cheat a little bit and just describe a little bit of what I tried to do in chapter 5 and 6 in part 2, because it's important to understand
Absolutely. Yep.
the consequences and where we are today. So essentially, what happens in the post-war period is we still have massive amounts of subsidies to the healthcare system. I already mentioned the Hill-Burton Act, massive amounts of funding to the development of hospitals across the U.S. But what happens at that time, because of the McCarthy era, and I really talk about the kind of impact of McCarthyism on healthcare discourse and sort of health policy discourse at that time. And it really takes what was a brief period of grow and reveal and shifts it back to grow and hide. And so what happens is, even though we continue to finance healthcare, we, in an even more drastic way, hide what we're doing. And in part, that happens by the political actors themselves, because they don't feel that they're in a political environment in which they can talk about what's really happening. But it also happens because the private sector becomes more empowered to begin to reify what these public subsidies are. And so I really spent some time in chapter 5 and 6 talking about the role of the American Hospital Association and the way that they begin to describe public subsidies as insufficient, as residual subsidies, as care that doesn't really cover the cost of indigent care for the indigent, that they're not able to provide the care they should be providing to good paying Americans because the government is underpaying. And so they kind of just drastically shift what's been a really pretty generous provision to the hospital sector as residual and kind of really demonizing the role of government. And that's important because we tend to think, oh, government really became more demonized in the 1970s. That, like, when we look at surveys of sort of like Americans, the American public's opinion of government, it's fairly high in the 60s, and then we see this dramatic, downward shift. Going forward. And now, of course, we know the opinion of US government is very, very low. But I try to show in the book, at least on the healthcare side, that that's being shaped very much by the private sector, the demonization of government, and kind of sets the stage for what we see in 1965 going forward. And so by the time we get, ironically, what I tried to say is the grow and hide regime of kind of putting us in this situation where we've used substantial public financing but hidden what we've done, and the demonization of government happened even before we passed Medicare and Medicaid. And I think that had serious consequences for then how those programs were able to develop and persist over time. So one major consequence is that in the 1970s, we were focused pretty substantially in the early period on healthcare planning. That the idea was, okay, if we pass Medicare and Medicaid, substantial financing, health insurance financing of the healthcare system, the government has to have some role in planning that healthcare delivery system. That was always the goal of the public health leaders, even that this comes from way back, and I try to document that in the book. But it just fails miserably in the 1970s. And it fails in part because government again makes it voluntary, so it's a very weak regulatory passage of a major planning act, but it also fails because the hospital system already has control of the discourse. Is sort of the private sector has control of the discourse and is able to just undermine this role of planning. And so by the time we get to the end of the 1970s, the private sector has defined government's role in planning as government regulation, even though it really was voluntary planning. And I think that is a really important strategic shift to call it regulation, because in fact, we've never had a strong regulatory state around the infrastructure development, around the healthcare delivery system. And so when you've already said, oh, we tried regulating the healthcare system and the government failed, that's a really important, establishing that discourse, I think, was very important and launched the kind of competitive approach in the 1980s and to present. So we also have then, of course, from 1980 to present, the kind of competitive approach in healthcare that I think comes out of Grow and Hide, because government subsidizes the role of capital in the U.S. healthcare system. That's really what I talk about in Chapter 8, and helps explain the rise of private equity in healthcare today. And then in Chapter Yeah.
Sorry, I was just going to ask you. Can you talk about that a little bit, because I thought that was a particularly interesting and dispiriting discussion, looking at the ways in which private equity has become so central, not just in hospitals, but especially in hospitals.
Yeah. Today, private equity. This was another example of doing research for one book and realizing you have another book waiting for you, which is the book waiting for me now is Financialization in Healthcare and the Role of Private Equity. But yeah, so today their private equity is involved in absolutely every sector of the healthcare system. It isn't just hospitals. But in the book, I really focus more on kind of what was happening around subsidizing capital investments in hospitals, because that's really where it kind of first happened through the tax-exempt bond. But what's important about that is it was government guarantee of reimbursement to the hospitals and reimbursement of interest depreciation to hospitals. There's a lot of details around this, which I will just leave out. But the reason that was important is that the capital markets, hospitals went to banks prior to these subsidies to try to get loans for capital for construction, for new construction, new technology. But the banks didn't see hospitals as a very good risk, because they it's not a private business, right? They saw it as quasi public, and they also knew that government was providing most of the grants prior to 1965, and so there was a sense that we already have.
Why should we step in?
Right. But when government started to, and especially through the Medicare program, to subsidize the interest payments, that made it valuable to the capital markets because it was sort of a sure bet. They got the tax exempt bonds, so they could, for their investors, they for every dollar invested, it was tax exempt, and then they knew that hospitals were going to be reimbursed for the interest, so they could certainly. So it was a safe. So it just reduced the risk. So that's what I kind of describe as like a very, very important beginning stage that government started the role of capital markets, and then kind of retreated from providing that funding, public funding, to hospitals and let the capital markets take over, and but still providing these hidden subsidies. So what we have today is, for example, I was just listening to the editor-in-chief of Health Affairs was on a panel thinking that was focused on the role of private equity in healthcare today. And super knowledgeable guy. Obviously, he's the editor of a major health policy journal in the US and has worked in government and nonprofit his whole career. But he started the panel by saying, "Well, of course, we have a mostly private healthcare system in the U.S." This is a quote from him, and so in order for that system to function, you need access to capital. So I'm trying to figure out what's unique about private equity, given that we need capital investment in the healthcare system. So what's happening here is, the guts of what I'm trying to lay out and Grow and Hide, right? One, he starts out with the myth, the predominantly private healthcare system. And then two, the myth today that follows from that is if we have a predominantly private system, then we have to rely on capital markets to finance that system. And so private equity, what's so bad about why is private equity worse than any other bank that's providing capital investments? And so there's such a broad acceptance of what is actually not even true about our system. Yeah.
So as we work our way toward concluding, Colleen, let me sort of ask you, we think about the Affordable Care Act, right? Arguably the largest, most significant recent effort at, I'll let you describe what it was an effort to do. But for listeners who may not know, there was an effort largely identified with a Yale policy scholar named Jacob Hacker to include a thing in the exchanges called the public option. So instead of there only being these private insurers that you could go to on the marketplace, heavily subsidized in order to buy insurance, that there would also be essentially, it looks like different versions, right? Open up Medicare and anybody who wants to buy in can get access to that. Had that been enacted, do you think that that could have significantly disrupted the pattern that you're describing, or would it have folded right into that Grow and Hide pattern? And we would, what do you think would have been the consequences in the way in which you're thinking about how we should think about the healthcare state?
The public option question, I think, is a really interesting one, because what it does is highlight that, if it's the public, as you said, it could have been structured in a couple different ways. The way that Jacob was talking about it, Jacob Hacker, was that it would be kind of connected to the Medicare program, right? That sort of like you would just buy into Medicare. And so what's very interesting about that is it suggests a couple things that so Medicare is public, but what's being offered on the exchange is not supposedly public, even though, as you said, it's heavily subsidized. So it actually kind of muddied this notion of what I'm hoping for is that the American people can have public subsidy should be completely transparent. And I don't know exactly how we make that happen, but that to me is the most important thing, is that if we knew what we have already invested in, I think the American people would demand a return on their investment. Right? They would demand that they have better healthcare access, that healthcare is more equitable because they've already paid for it. And so I was kind of troubled by like, oh, this is public. The public option is public, but this presumption that the other options on the exchange would not be public. Also, what's really weird about Medicare is, as I'm, there's Medicare Advantage, and I think that's contracting out with private managed care plans, which has now made so many elderly completely confused about the very like Medicare, which we call our closest thing to national health insurance. Many elderly think is private insurance, and I'm sure you've heard those quotes.
And for many of them, it is, if they're on those
Exactly.
advantage
And it
plans. Yeah.
has, because we don't do a very good job. We do a horrible job actually regulating those private plans. You know, they're allowed to act like private insurance companies as well, right? Denial of claims, prior authorization, all of that. So I also would have worried a little bit. I mean, I'll stop on the public option. I think it's a really interesting question, and I could go on. The other thing about the Affordable Care Act is it did just embed us even further into subsidizing the private sector, obviously through the exchanges, but also on the Medicare expansion side. Most of the states that do, almost all of the states that do Medicaid expansion, which has been hugely important for coverage. I don't want to diminish the importance of that. But again, they contract out with private plans, and they're big commercial insurers, and it's really a number of states have a difficult time reining in these private plans now, and I'm not sure we're getting the deals that we need to be getting out of the amount that we spend in the Medicare expansion. I'm sorry, Medicaid expansion.
So this is the Public Policy Channel of the New Books Network, and you have been listening to Colleen Grogan skim the surface of what is a genuinely fascinating new book that for those of you who have any interest or knowledge of this, I think will help you rethink the way that we think about the U.S. government's role in health broadly. And maybe if enough people start to do that work, right, that will create the opportunity for us to attain that kind of transparency that you were talking about as perhaps the first level of creating a political space for rethinking this. The book is Grow and Hide, The History of America's Healthcare State by Colleen Grogan, new from Oxford University Press. Colleen, thank you so much for joining us. Much appreciated.
Thank you so much, Stephen. It's been fun. Thank you.